Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
And good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about addiction, the different types of addiction, why some of us are more susceptible to developing an addiction, and of course, treatment options. Tonight's guest is psychiatrist Jennifer Velander. In the second half hour of our program, we're going to be doing things a little differently. Just because of the nature of tonight's program, we're going to be taking just emails. Here's our email address, hhquestions@wlae.com. That's hhquestions@wlae.com. We're showing you the phone number too, because if you don't have access to email tonight, but have a question for us, what we'd like you to do is put it in a single sentence, if you would, something short. Feel free to call the number, 866-3200, and tell us what the question is. We'll put it in the form of an email for you and get to as many questions as we possibly can for tonight. Well, Dr. Jennifer Velander got her medical degree from the University of Michigan Medical School. That's in Ann Arbor. She completed a psychiatry residency at the Payne Whitney Psychiatric Clinic, part of the New York Presbyterian Hospital and Weill Cornell Medical Center in New York City. She then completed an addiction psychiatry fellowship with Beth Israel Medical Center in New York. Dr. Velander is a member of the American Academy of Addiction Psychiatry and the American Psychiatric Association. And it is our pleasure to welcome Dr. Jennifer Velander to Hello Health. Good to have you with us on the program. Thank you for being here. So how did you first get interested in psychiatry? We'll start there and then we'll move beyond that.
Well, I really enjoyed my psychiatry clerkships because I went into medicine because I wanted to help people, and I found in psychiatry you just talk a lot with people and you get to hear a lot of great stories and really get to know them personally.
Okay. And you are an addiction expert, so how did you end up in that particular area of psychiatry?
In my psychiatry residency, I found patients with addiction the most rewarding to work with, because once they get into treatment and get on top of their addiction, they actually can get so much better.
Without any details, obviously, but all of us have been touched by addiction in some way. Were there any personal stories along your own life that have made you feel more strongly about this? Again, with no specifics.
No, there weren't any particular specifics in my own life, although, we all know people. There's countless small incidences and also just people I've met throughout my medical training.
Yeah. We're going to be talking about marijuana and heroin a little later, but we're going to start with opioids and the opioid epidemic. Is it an epidemic, and why should we be concerned with the use of opioids?
Well, I think it is an epidemic, and many people and organizations have called it an epidemic. The Surgeon General, the CDC are all calling attention to it. And it's an epidemic because of both the severity and the number of people are affected and the lethality. As a slide that is put up is going to show that basically more than the number of people who are dying of opioid overdoses is greatly increasing. And now in 2014, for the first year, it exceeded the number of people who died from motor vehicle accidents. And here in New Orleans, we also are having an increase in mortalities as well too. The number of people in 2016 doubled from 2015, and we had more homicides, more deaths from opiate overdoses than we did from homicides last year. And this chart shows also that opioid overdose deaths are increasing basically across the class of opioids, both through prescribed opioids, but increasingly more and more with heroin and synthetic opioids, which a lot of people are turning to replace prescriptions.
That in this next slide too. There we go. Yeah. Is it true? I think I heard that there are more prescriptions for opioids in the state of Louisiana than there are people?
Yes, there are. That it is just very common across the state. It's very common across the country.
And it doesn't mean everyone in the state of Louisiana is getting an opioid script, but what it does mean is that people are using them and going back and getting more prescriptions.
Exactly, or getting them from multiple prescribers.
Okay. And what has led to this epidemic? Are more people getting, it's used to treat pain, and we're going to talk about that in a moment, but what do all the experts say has led to this epidemic? Opioids have been used for how long?
Opioids are, they've been around for millennia. They're all derivatives of the opium poppy plant. And there's initially people were just using the pure plant and the pure products of the plant, and those would be the more classic opioids. And some of the constituents, things like morphine and codeine, which were isolated.
Let's show people what an opioid plant looks like. They're not out in the backyard every day, but let's show, there we go. So it comes from a plant. That's
exactly.
Right.
And so some of the opioids that we use are isolated directly from the plant, and some of them are modifications of components that we find in the plant. So the more natural forms would be codeine or morphine. The modified forms would be the semi-synthetic opioids like heroin or Percocet, some of which actually heroin was initially designed to be a drug or to be a therapeutic drug that people could be prescribed. It was actually thought to be less addictive, but we found that's not the case. And then we also have synthetic opioids, which are chemicals that are made to act a lot like opioids, even though they're not naturally derived from them.
Okay. And who's making all these? These are drug companies making them?
So drug companies, for the most part, are making them. But however, there are also lots of laboratories that may be producing them illicitly and selling them for sometimes research purposes, but a lot of times for recreational or illegal purposes.
All right, we'll talk about that more in a moment too. Now, and let's be clear, some of these medications are necessary, right?
Absolutely. Opioids can be very important to treat acute pain. Somebody who's in a motor vehicle accident, has an acute injury, needs surgery, or people at end-of-life issues with intractable pain. But it's more all the other areas where the risks and the benefits become much less clear. And just to get a sense of this, we just use so much more opioids in the United States than the rest of the world does. Even other very modernized countries in Europe, such as Germany and France, we consume 80%. We comprise 5% of the world's population, but we consume 80% of the world's opioids.
Why is that?
It's a very long, complicated question. I think some of it's related to some of the addiction problems in this country. Some of it's related to, I think, the diligence and good intentions of many physicians and of the pharmaceutical companies. But some of it also may be related to, possibly some people wonder also a little bit of greed on some parts. But a lot of it was actually made out of good intentions, because people want to cure. Doctors are hope. We want to cure people. We want to solve pain, but maybe we've gone too far.
Now, when I think of end of life, I think of morphine. How does morphine factor into any of this?
So morphine is a natural derivative of the opium plant. So it's one of the natural opiates. It is a prescription, though, that's processed and made on an industrial scale, and that's also made into prescription drugs. So it can be used for end-of-life care, as can any of the prescription opioids.
So some people are going to be addicted to opioids, other people are not. What is the percentage of those people?
This is very hard to tell who's ultimately become addicted. There's various different studies that look into it, try to figure out who can become addicted.
Well, that's the next question, right?
Yes. But we don't actually have a good answer, but we do know that the longer people are on these medications, the more likely they are to become addicted to the medications, and also that we don't necessarily have a good way of predicting who will or who won't.
Are we working on that? Because if we
Yes.
knew who was going to be addicted, we wouldn't give it, would we?
The question, though, becomes, is there a period of time in which, there's no safe amount or period of time that we can use opioids for, because there are various processes that people become tolerant to these medications.
What is it about opioids that make it addictive? Is it the euphoric high that it produces, or is it something else?
I think that there is to some degree, the euphoric high. Opioids, like all addictive substances, ultimately interact with the dopamine receptors in the brain. And these, anything that activates these dopamine pathways can ultimately be addictive.
So when I use the term natural high. So when we go to a Saints game and we win on the last, we meaning, from here, we win on the last play, is dopamine being released in my brain?
Yes, absolutely. Anytime there's any kind of pleasure or reward, but there's some natural systems in the brain by which dopamine is being released, and that may be involved with learning and reward and motivation.
Helping an old woman across the street.
Exactly, and that sort of, that rush, the pleasure you get from seeing somebody smile or feeling like you've done something good, as opposed to the, but also using drugs can activate the same system but through a different path, and the problem is that path gets reinforced over and over again with the use of these substances.
So who should be treated with opioids and who shouldn't? And it's not that simple.
No, I don't think it is that simple. We don't know exactly who would be at risk for addiction, and furthermore, there's so many different things that go into pain. Are pain medications always indicated? I want to give this one clinical example of, actually, it's two patients, both of whom are construction workers and had workplace injuries. One man, and there's going to be there's a slide that we'll be showing that has a man who basically jumped down on a nail by accident, was in excruciating pain, brought to the emergency room, given large amounts of IV opioids with no relief, and eventually people thought, well, let's remove his boot and see what happened. And they took his boot off, and the nail had actually gone between his toes and had not even scratched him. Another example of another workplace injury with another construction.
So strictly psychosomatic.
Strictly psychosomatic. Another person who is also a construction worker with a workplace injury accident was using a nail gun, shot it off, and then the nail went somewhere, didn't know where, went home at the end of the day with a toothache, which continued to get worse and worse and worse until finally his wife encouraged him, you should probably go to the dentist to get that looked at. And then they took a picture, an x-ray, and they found that the nail had gone through the roof of his mouth and through his skull and into his brain. Now, they both ended up being fine, but it's just to give you an idea of what goes into the perception of pain, that it is much more than just the injury itself. It's vision, it's your mood, it's your perception.
And some of us have a higher tolerance for pain, and some of us a lower tolerance for pain.
And there's lots of different factors that go into that.
Okay. There are other ways of treating pain, so why do we use opioids at all?
Well, there's lots of different pathways involved in the pain. Opioids are one very quick way of eliminating acute pain. But as I mentioned before, there's so many different things that go into it, and perception and your mood, and even just the pain fibers themselves. There's many different modulators, from various different depression-related neurotransmitters to different types of ion channels and different pathways that we can all modulate and we can all affect, either by exercise or yoga or other relaxation techniques, plus also other medications involved in inflammation or involved in neuromodulation. So opioids, a lot of these may take a little bit more time, but ultimately they may end up being more of a sustainable medication, because unfortunately with opioids we will see tolerance.
Are opioids actually getting rid of the pain, or are they blocking the pain?
So opioids don't directly address the cause of the pain. So usually there's some kind of injury, and there's, as the pathways show, there's numerous other inputs that go into it, but opioids don't address the direct cause. Basically what they do is they mask it for a period of time.
Okay. And I know one of the concerns for doctors like you and others is opioids and them leading to other things, heroin, for example. And what do the studies tell us about heroin users?
So actually 75 to 80% of heroin users initially started out with prescription opioids. These weren't people who just decided to go start using heroin or experiment with heroin. They got opioids from either a friend or a relative, or they found it in somebody's medicine cabinet, or they bought it off the street to experiment with it. And so that's why it's particularly important, why we as doctors need to be careful about how much we're prescribing, because that's leading to that. It's leading to people going out to eventually to heroin. And there's lots of other risks associated with these medications as well too.
What do we see here on this risk and tolerance scale?
So risks, so there's a lot of different adverse effects associated with opioids, and some of the possibilities, we mentioned overdose. Basically these medications can lower your respiratory drive and make it much more likely that you could stop breathing, particularly if used in combination with other sedative medications. There is a side effect called hyperalgesia, where actually opioids cause a paradoxical increased sensitivity to pain, and that actually people's pain will get better once they're tapered off the opioids. There's tolerance that develops in everybody. That's, if anybody takes these medications for long enough, our bodies become used to it, adjusted to it, and we need more and more. And then there also is addiction. We used to think that if you had pain, you weren't at risk for addiction, but now we realize that no, we can't predict, and just having pain itself is not protective against addiction. Now, tolerance is a phenomenon. Not everybody who gets tolerance to these medications will become an addict. However, it is a step on the pathway there, because what ends up happening is you're tolerant to the medications and you may need more and more of them, and then that increases your risk for addiction. Basically what tolerance is basically needing more and more of a medication to get the same effect, or finding that if you do take a certain amount of medication that you've always been used to, it's just not working the same anymore.
You talked about the heroin user who gets it from a friend, or somebody gives it to them, or whatever. You didn't talk about the person who's prescribed opioids.
Absolutely.
Can't get them anymore. Do those people sometimes turn to heroin?
Absolutely, they can. Because what will happen is, now not everybody, probably the most majority of people who are using these medications may not go out and do that, but to a certain point, once the addiction process has started, it's going to be expensive and difficult to end up getting enough of the opioids through prescriptions. Basically, you're not going to be able to get doctors to prescribe it for you. You're not going to be able to afford to pay for it. And heroin is much more widely available and also inexpensive, and easier for people to get, at least illegally.
Okay, I want to go back to one of our earlier questions about more prescriptions than people in the state of Louisiana. That's because patients go back to get more and more. Are there patients who go from doctor to doctor? Because if I go to if I keep coming to you and you say, Tom, you've had enough, you're done, you're addicted, we're going to get you off of this. If I don't like you, I'm going to go see somebody else. Does that happen?
Absolutely, that can happen, because there are some people who, some of the people due to addiction may do it, but also some people who are tolerant to the medication that are really trying to get pain relief. And they may find that, okay, I'm not getting enough from this doctor, well, maybe I'll see if this other doctor will get this for me. Or they might go to emergent ERs to try to get more. And a lot of times it's not done with the intent of, I'm doing this to get high. It's just that, well, wait a minute, I'm really in pain. I need to get help. And these pain medications aren't working anymore. Let me go to the emergency room and let me get more of them. But that keeps happening, and it becomes a cycle and goes on and on.
Okay. So I happen to be an Ochsner patient, so everything that happens at Ochsner, all of you all know about, and HIPAA, laws protect from that. But there's no sort of central system, right? So if I go from hospital to hospital or doctor to doctor, there's no way for one doctor to know he's been to see 6 others, right?
Not necessarily, although there is a prescription monitoring program that's active in the state. So many states have a state prescription monitoring program. And what it will do, it will let us know if a prescription for an opioid has been dispensed to you. And doctors are, in fact, there's new legislation that's going to mandate that doctors have to check that. But right now, doctors do not have to. And also, if patients go to emergency room and they're going to emergency room for just kind of, acute care, that may not be reflected in that.
I'm not saying that's a bad idea. I think it's probably a good idea, but how do you get around HIPAA laws with that?
Because you're caring for the patient. And because it's basically limited to the information that you
Within
need.
the medical community. Okay. How can someone tell if they are addicted to opioids, or if someone they know is addicted to opioids?
Well, there's various signs that you can look for. One is that you're craving the medication. You're thinking about it even in advance of taking it. You're wishing you had more. You're using it for purposes other than which it was initially prescribed. You're finding that, okay, if I, this helps me with my anxiety when I go out in social situations. It gives me some energy. It helps me get up in the morning. You're, doing some of that doctor shopping that you described before. You're not getting enough from one doctor, so you're going to someplace else, or you're going to different emergency rooms. You're getting from non-medical sources, so you may be borrowing from your friends or someone else, or you may be trying to buy on the street. You're using more and more and feeling like it's out of control. Also, you may be using other substances to kind of potentiate the effect. So some people may find that, some of these medications like Xanax or sedatives can also potentiate the effects of it. The other possibility might be that you're using, these medications are supposed to, make people feel better and improve function, but your function's starting to go down. Or that you're having some adverse medical or psychiatric consequences like depression, or there's gastrointestinal side effects associated with it, and you're still continuing to use.
All right. We're obviously offering information tonight, but we're also trying to be helpful and hopeful. Lots of other things that can give you those same looking forward to, right? Like exercising in the morning. There are people who can't wait to go exercise in the morning.
Absolutely.
Same euphoria, same looking forward to it, but good for you compared to the alternatives here.
And that goes back to the whole addictive process, that these substances do activate the addictive circuits in the brain where the dopamine is released in a very direct way and bypass some of the more higher processing areas of the brain that also can lead to dopamine release, but sort of through a more kind of gradual process. And so these different types of rewards kind of get out of balance with addiction.
Overall, are some people more susceptible to addiction, to all sorts of addiction, not just opioids?
Absolutely. There is an element of genetic susceptibilities that we're starting to find out more and more of. So these things there is a hereditary component. Twin studies and other genetic studies have definitely found a link that have separated genetic factors from environmental factors. But we also know that trauma, early life trauma, can also be associated with it. Depression can be associated with it.
Okay. Where do illegal opioids come from, and where does heroin come into all of this?
So as we mentioned before, that a lot of times what happens when people get more dependent upon these medications and they can't quite get enough to fulfill the same either pain relief needs or euphoria needs, they may look to things such as heroin, which is cheaper. And at least on the street, readily available. There are other medications that are also been developed, the synthetic opioids that I alluded to before, that are developed in laboratories and sold, illicitly. And a lot of times people think that they're getting, they may be getting a certain substance. So people may think that they're getting heroin, or they may think that they're even buying a prescription opioid off the street, but it may actually be contaminated with or intentionally filled with some of these synthetic opioids, which are actually far more potent and lethal substances.
And are these manufactured here, or most of them manufactured overseas and shipped in?
A lot of them are actually manufactured overseas. I know China's a big source, but there are other countries involved too. There are some manufacturing done over here as well too. But because these opioids are so potent, basically a small amount can be used to have the same effect. They're much more easier to transport, and they're also cheap to make.
Let's dive a little deeper into some of these illegally manufactured opioids and the names we'll be hearing.
Okay. So we're seeing this more and more. In fact, the CDC has reported that just an exponential increase in the amount of these synthetic opioids contaminating prescription opioid and heroin yields, basically, for instance, when the authorities have seized them, that we're finding so much more of them laced in there, or actually kind of replacing it. Something that looks like it's actually heroin, or something that looks like it's an oxycodone is actually something compounded together with fentanyl or one of these other synthetic opioids to look like it. So it's actually something that's far more potent and far more lethal.
And why did they manufacture it this way? Is it cheaper to do that? Is it a greater high, therefore it will be in higher demand?
Both. So these are ones that can be manufactured in a lab. You can have a more potent response with a smaller amount, and they're cheaper, and they're easier to transport and easier to hide, and ultimately more addictive, but also more lethal.
And the reality is you don't know what you're getting if you're buying it off the street or getting it from a friend or something like that.
Absolutely not. And so if you're getting it from a pharmacy, it's probably what you think it is. But if you're buying it off the street or getting it from a friend, you have no idea. And tragically last year, Prince, the singer, had died of an opioid overdose. And what they believe may have been responsible for this was some of these synthetic opioids, because they found traces of fentanyl and another new synthetic opioid called U47700, which is also known as pink. And that traces of these were found in his blood, as well as in prescription opioids found in his house that looked less like, your normal Vicodin or oxycodone, and that what you might have thought was, but they actually were compounded kind of fake versions of them containing these other synthetic opioids, which are much more potent.
So we know in his case, stronger or synthetic meant more dangerous. Is that always the case? Does stronger necessarily mean more dangerous?
Yes, definitely. There is a higher risk of overdose because it's much more unpredictable. Basically, fentanyl, the overdose risk for a certain amount of fentanyl is so much higher than it is for heroin.
You really see that in this image you brought.
Absolutely. So these are comparable lethal doses of heroin and fentanyl. And fentanyl, basically, it's just, it's like a few grains of salt worth. Now, there are even more potent synthetic opioids out there, like carfentanil, which has sometimes been seized recently, and that's 100 times more potent than fentanyl. And you can see how potent fentanyl is. You can just imagine the lethality of these. And so people may think that they're using a certain amount to get high, but they may not be able to control that use because it's just so hard to control that tiny amount.
All right, let's talk about the science of addiction. So you're a psychiatrist. Where does it all start?
So we know that this is a medical illness. Addiction has become recognized as such. So similar to things like diabetes, to hypertension, this is something that is a chronic illness that people have to be monitored for and have to be, kind of evaluated for the rest of their life. People can get it under control, but the relapse risk is still there. We know that addiction has many components to it. There's genetic, environmental components to it. A lot of it ends up is basically, it is still predominantly a brain disease. So it happens in the brain. There's a certain area of the brain that I alluded to earlier called the ventral tegmental area, which basically leads pretty much as the downstream where pretty much most addictive substances end up kind of coming into. And they all then there activate these dopamine neurons that then release dopamine into a part of the brain called the nucleus accumbens. Now, this is kind of a simplified version of it, and I am throwing out kind of some long names, but
it's a medical show.
It's a medical show.
That's right.
That's where addiction predominantly occurs. So is in that area of the brain. It's hypothesized now, but various different substances can all kind of activate through that area.
Okay. And what is it that causes people to use?
Well,
obviously it's not always just the euphoric high. It's the masking of other things, right? What is the motivation? What do we find behind people who use on a regular basis who are more susceptible to becoming addicted?
So it can be the euphoria. It can also be a way of escaping. For some people, it's also, usually if you press people, you can find some kind of a psychological reason, and it's useful to work on that. However, for some people, it's something even just deeper, like a craving, something that they just have a hard time, difficulty controlling of. So you try to work from both aspects. You try to work from more of the psychological aspect that you can get into. So sort of what are you trying to escape? Are you trying to sleep? Are you trying to self-medicate? But that, on some level, it also ends up being just a kind of a biological impulse that people are finding harder and harder to resist and sometimes have difficulty verbalizing. All
right, let's show people the brain and take us into where the process of addiction starts again.
And so I described this a little bit before, that any addictive substance ultimately will end up activating this pathway where the VTA, or ventral tegmental area, will then basically lead to dopamine release in the nucleus accumbens. and then that itself reinforces that circuit over and over again, and then goes back into the prefrontal cortex, which is the area of the brain involved with planning and decision making. But this is kind of a backwards process, because for what we're when we're learning and as we're growing up, we basically want to use our reasoning in our higher parts of our brain, such as the prefrontal cortex, to control the other areas. But with addiction, that whole process comes topsy-turvy or upside down, whereby a lot of the more kind of basic reward systems start taking over, rather than using the more executive parts of our brain, the parts of our brain involved with delayed gratification, with more enjoyment of more higher pleasures in life.
What you described to me is one is a lot easier than the other.
Yes. So one is a lot easier, one's a lot simpler, one is a little bit more instinctual. The other one does definitely, that's where willpower comes in. And so that is one other way of putting it, is that addiction is a disease whereby, yes, there is a choice, but it's largely a biological kind of overthrow of the willpower.
Well, we've talked about the epidemic, and certainly it's in our common culture now. You can't turn on the radio or turn on your television without hearing about some program or some place that's willing to treat addiction. So let's talk about how addiction is treated today and how that's changed, and really how the whole mindset has changed about first admitting that there are problems out there, right?
Mm-hmm. Yes. So now there is a lot. Before, addiction used to be seen as a vice, a moral failing. It's something that people just needed, or even just needed punishment for.
That's what those people do, right?
Yes, exactly.
Yeah.
So just either separating people or sending them to jail. But now we're coming to realize, there's diversionary treatment programs, but also just development of different forms of treatment in general. So there's great psychosocial treatments that have been around since the middle of the 20th century, things like Alcoholics Anonymous and Narcotics Anonymous, which are great therapy and psychosocial treatment. So meaning like it's a community, it's a source of support for people, and there's good evidence for that. There's also great evidence for cognitive behavioral therapy, for mindfulness-based therapies. So a lot of talk therapy can be helpful in having that community and having that support. However, we also find that more and more, because this is a medical illness, that medications are really important, and that medications can greatly reduce the risk of relapse.
Okay. Talk to me about the group therapy component, and get somebody over the fear of, wait a minute, I have a problem, I haven't even told my family about it, why am I going to go tell a group of strangers, and the fear of how that might affect the rest of someone's life.
Well, in fact, that's exactly why it can be so therapeutic, because you're around a group of people who have similar problems. So the shame and the stigma can be alleviated. You won't feel judged. There will be a sense of acceptance, as well as mutual help and suggestions. So it's actually very powerful.
Okay. And talk to me about the difference between going, because we hear more and more of the ads for day treatment, because not everybody can take 30 days off or 60 days off and just say, let me pause life. We can do that with the TV. It's tough to do that with our life. Do these the difference between going away and being treated and doing it on a daily basis?
For many people, either one can be a valid form of treatment. There's pros and cons to both. The thought is that particularly for more severe treatment, for more severe addiction, people might need a longer, more intensive form of treatment where they're removed from their environment. But that for many people with addiction, actually having the treatment right there in the process of your home, while you're still at home, but just going someplace on a daily or almost daily basis can be really therapeutic, and having lots of groups and having medication treatment. So it's typically a first line intervention.
Okay. And do most insurance companies cover this? And what about the people who don't have insurance?
So most insurance companies will cover this. Now there are also alternatives through the different parishes for people without insurance, for people who are underinsured or who have Medicaid. And so there are websites and contacting basically your local parish for a list of community resources.
Okay. You mentioned diversion programs. Has law enforcement kept up with this trend of understanding that it's a disease rather than necessarily bad choices?
I think we're all trying to catch up at this point. But I think that it's a process, and I think that all the diversionary programs are a recognition that this is maybe something that needs to be treated rather than punished.
Okay. What medications, you mentioned using medications can sometimes be important and helpful. What are some of the medications used to treat opioid disorder?
So some of the medications, one of them is naltrexone. So one thing we find though with opioid use disorder is that 90% of the people will relapse. So even after having a detoxification, an adequate detoxification and a 30-day inpatient program,
I'm clean, no problems.
Yep, within 90% will still relapse at some point within the next several months. But however, if we use medications with this, we can really reduce the rates to 60% or even lower of rates of relapse, which is 60% compared to 90% relapse is tremendous. Now this graph now of relapse rates with naltrexone shows that basically you can, the red shows the people who are on naltrexone and that how much more of them are in retention and staying sober with that medication compared to ones who are not getting the medication and just getting other forms of default psychosocial treatment.
There are a couple of other drugs used too, right?
Yeah. So naltrexone is a great medication. It's not addictive. It works by blocking the opioids. It is basically by blocking the opioids, it kind of helps to decrease cravings, but also works to kind of, as a deterrent, because opioids won't work. In fact, you may actually precipitate withdrawal by by taking opioids while you're on naltrexone, and it's available in an oral form and also in a once-a-month injection.
And what about these the other two?
So some other medications, there's methadone, which has been around for a while. That's typically prescribed through a community setting. But a new medication that's been getting more and more interest is buprenorphine or Suboxone, which is a partial agonist. So it works a lot like an opioid, but it has a ceiling effect. So you cannot get above a certain point. Basically, you don't have that high associated with it, and you don't have the risk of overdose associated with it, because beyond a certain point, when you get it in your system, it just stops working. You don't get more and more of that opioid. There tends not to be the same degree of tolerance, and also if you try to use other opioids on top of it, it would block their effects. So if given in the structure of a good program, it could actually prevent people from using opioids.
And what about the final one?
So the other medication that's something that people need to be aware about is naloxone or Narcan. That's less a treatment for opioid use disorder and more of a treatment for opioid overdose. So if you find that you are taking opioids and you have taken too many, which is a risk and it can be pretty unpredictable, particularly if you are taking something illicitly off the street, that if you use this medication, this can, or someone you know, or you basically if someone you know uses opioids and a loved one does and you want to be able to help them, having this medication around is very, very helpful, because you could basically, if someone stops breathing, this can save lives.
This is the EpiPen for opioids.
Basically.
Okay. So let's talk about marijuana and what you're seeing in your office and at Ochsner, and talking with other doctors about the rise in marijuana use here in the state of Louisiana. So
marijuana use, is basically the question that's coming now is that we are facing, it is going to become legal. It has been, a law has been passed making it legal, but there are still some administrative hurdles, but it will become more and more so seen. But I think a lot of the difficulty with marijuana is that I think nobody really knows that much about marijuana yet. People think that marijuana is one substance, but unlike opioids, it's not just one thing. It's not just that you take marijuana and it interacts with the marijuana receptor. There's actually numerous cannabinoids and psychoactive substances in marijuana, so it's not just one particular substance, and we really don't know that much about it yet.
All right. There are plus sides to marijuana and lots of downsides too. We're going to talk about those in just a moment. But first, we want to let you know we're talking with psychiatrist Jennifer Velander, and we're talking about addiction tonight. We're going to talk about treatment options as we continue to do that in just a moment. We do want to let you know we won't be taking questions by phone tonight, just due to the nature of the program. But if you have a question, you can send us the question by email. Our address is hhquestions@wlae.com. That's hhquestions@wlae.com. Or if you have a question and don't have access to email, we're thinking about you too. Our phone number is 504-866-3200. However, what we'd like you to do is get your question together in about a sentence or two, something short that we can put into an email for you and try to get that to the program tonight or with the doctor at a later date if we're unable to get to it. And we do expect lots of questions a little later. So how does cannabis, you mentioned that marijuana just isn't one thing anymore. What are all the things in marijuana, and how has marijuana changed over the years?
So marijuana is composed of over 100 different psychoactive cannabinoids.
One plant,
One
lots
plant.
of things inside of it.
Exactly, and there's also something else called terpenoids, which are these other substances, of which there are numerous, that modulate the effects of the cannabinoids. So lots of, one plant, but many different substances, and every plant and every strain tends to have different ratios of these. So it's very hard to know exactly what you might be getting with this. Now, over the time, the marijuana plants have been cultivated to have stronger and stronger amounts of the THC component, which is the more addictive component. So a lot of times what people are getting nowadays is not the same thing people were using 50 years ago. It's actually a much more potent, more addictive plant. So there's two major cannabinoids that we are aware of. So they're the 9-tetrahydrocannabinol, or THC, and that's the one that is very reinforcing, has a lot of euphoria, has addiction associated with it. It also, so people may like to use it because it has a lot of things like increased energy, the euphoria. However, it has a lot of downsides, such as loss of coordination, also possibly some cognitive side effects, paranoia. So that's the one that both people may be looking for, but also may have more of the negative psychiatric and physical side effects. CBD, or cannabidiol, is the other major cannabinoid that we're interested in. That's the one that probably has most of the medical benefit. It's
let's talk about some of the medical benefits.
Yeah, so the medical benefits that may potentially exist with marijuana, there is some evidence for potentially its use in epilepsy. There is some evidence for its use in pain. There is some evidence for its use maybe, certain, and again, when I'm talking about the evidence, I'm talking about for even particular elements of it. Now, because remember, marijuana has numerous components. So there is some evidence, particularly for cannabidiol, for some anti-anxiety or for sedation. There's not evidence for its use for things such as appetite, is a little more inconclusive. But basically, we still don't know that much yet.
Okay. What would you say to the person? So is marijuana addictive? Because you'll hear that over and over from young people. Oh, marijuana is not addictive.
It absolutely can be. 9% of all people who ever use marijuana will become addicted to it.
9%?
9%.
Mm-hmm.
It has it does have phenomena where people become tolerant to it. You can experience withdrawal, and it can still cause lots of negative psychological effects on users.
Okay. Where are we right now in the state of Louisiana on legalization?
So in 2016, a law was passed legalizing medicinal marijuana. However, this is still a very complicated thing to enact. There has to be all kinds of administrative hurdles in terms of zoning and how it's done and under what circumstances. It will be medicinal, so it'll only be allowed for certain purposes. Spasticity related to MS is one, potentially epilepsy is another one. But so you still will need to go see a doctor and get a prescription of some form for it. It will not be for recreational use, but it's going to be a little bit of time, I think, until this happens. And it's also complicated by the fact that it still is federally illegal.
And we see billboards for it, or even though it's not available yet, we see billboards for it. In anticipation of it, we see billboards all over the city for it. So is it a gateway drug?
That's a difficult question to answer. It is
What have you found in your own practice with patients that you deal with?
So it is a drug that people most commonly will first start using. So the question is somebody who smokes pot, are they inevitably going to become addicted to something else? Not necessarily. However, is it more that people who have addiction, that marijuana is more readily available, and therefore it's going to be their first drug? Or is it actually something that increases the risk later on? We do know that there is a phenomenon called cross-addiction, though, that if you use some substance that has any addictive potential, you are activating that same circuit that I described earlier, the one with the ventral tegmental area going to nucleus accumbens, that whole dopamine reward pathway. And any addictive substance that starts to reinforce that is priming you for addiction later on. So there is some evidence that that may be the case.
And just like we don't know who's going to get addicted to opioids, we don't know who's going to get addicted to marijuana on the front end, do we, or do we?
No, we don't. And again, we may be dealing with a substance that is less addictive, but it still is addictive.
Okay. What are those effects that young adults are more susceptible to?
So, that is something there can be a lot of downsides associated with it that we're kind of seeing more and more of. We do know that ever since it's been legalized, they have found an increase in motor vehicle accidents. We know that there's an association with loss of coordination, also that there may be some attentional problems, but the effects in adolescents appear to be more severe than they are in an older person. So, for example, someone who started smoking marijuana in their mid-20s may not have the same effects, as many as adverse effects, as someone who started when they were 15. What we
hear the same thing about alcohol.
That's absolutely true too. The thing is that when people are teenagers and in their early 20s, it's still a key developmental processes going on. There's all these mechanisms whereby there's a synaptic pruning that happens. Basically, the brain gets kind of connections between the brain gets refined, and that this refining process, which is so important for learning and for cognitive development, gets kind of shortened or gets kind of stopped by a lot of these substances. And we definitely find that with marijuana, that there are differences between people who, they look at the brains between people who started marijuana use at the age of 15 versus 25, and there's substantial differences in the amount of that kind of brain development.
And for the record, we're not saying if you're 25, have at it, right?
No,
right.
No. It's more that there still can be downsides at the age of 25. It's just that the thought is that people in their adolescent years may be even more susceptible to them.
Are more people experimenting, more young people experimenting with cannabis? What do we see on the chart here?
So actually the issue isn't so much more people experimenting with it. That's actually been pretty steady over the years. The issue is more that more young people are using regularly, because I think it's probably tied into the idea that there is less harm associated with it. We found this before with cigarette use, that basically as the perception of cigarette use being dangerous went up, the amount of regular use of it in adolescents went down. But we're seeing kind of the contrary phenomena with marijuana, that as people are perceiving it as more of a benign substance, people are using it more regularly, and adolescents seeing as it's not such a big deal.
You have some young children in your home. What will you be telling them at the appropriate time about all of this?
I will be providing them with the same, maybe I'll show them the same interview that we're doing right now. I'll be trying to provide them with the same information. It's not a moralistic issue. It's just a question of whether or not these risks are really worth it.
And what advice would you have for parents who have had those talks with their kids, but those kids have taken another path and chosen to go down this road, and maybe by no choice of their own become addicted?
Again, I think that providing with information. I think knowledge is powerful, and if people are aware of the risks, I think that can help sway them. And then, offering help, trying to suggest help to them, and actually prevention often usually is the best cure for this. So talking to your kids in advance, and if your kids are still using, you still can continue to talk to them, because we do know that at any point you can intervene, and that hopefully they will not become addicted, but even if they do, addiction can be something that people can recover from.
When you came here tonight, what did you hope people would take away from this conversation?
So one is that there are a lot of substances out there that are highly addictive and that have a lot of negative consequences that we are becoming more and more aware of, particularly with the opioid epidemic. Just being aware, and before we get started on these medications, thinking about whether or not they're appropriate, and then constantly reassessing along the way, is this a medication that's hurting me more than it's helping me? And the same thing with marijuana, is just to be aware of the risks of this, and that we still have a lot more information we need to find out.
Speaking of information, I know there's some resources that you use, and you'd like others to have access to as well. Why don't you run through these if you could?
Okay. So There are, this is all from the drugabuse.gov website, so the National Institute on Drug Abuse. If you go to the website, you can actually send away for a lot of these manuals for teachers, for parents. They have a lot of manuals that are guided for classroom use, for things that you can just order that are aimed for teenagers to help educate them, to help with prevention of substance use, but also if you yourself are trying to find out a little bit more about a substance or whether or not you may be addicted or how to get help. So that's a very good resource. I also wanted to, precisely because the opioid epidemic is such a lethal one, and because these drugs can be so deadly, I just wanted to make everyone aware of the existence of naloxone and Narcan, that these are medications that now have standing orders at many pharmacies, CVS's and Walgreens across the city. So that means you can go in without a doctor's prescription and ask for them. And the Narcan are not addictive. They're medications that work by blocking opioids and can reverse overdoses, but they can be complicated to use, and that's beyond the scope of our interview today. But if you go to these websites, they can talk to you about how to get them and how to use them.
All right. Usually in our program, we'll take a break. We won't do that tonight just because we've spent a lot of time talking about a very important subject. And we've already received some emails too. We want to let you know that if you want to ask a question tonight, we're not going to be taking calls due to the nature of the program, but you can call this number, 504-866-3200. That's 866-3200, our usual number, and just give us your question. We'll write that down tonight and try to get it on tonight's program, or if not, try to get it to Dr. Velander to get an answer for you in fairly short order. Let's go to some of those emails we've received tonight. Here's the first one, Doctor. My doctor has left town and I'm not able to get my pain prescriptions. What are my options?
So I'm not a pain physician, so to kind of explain to you what to do in that situation, I don't know if I have a good answer for that question so much. If you feel that your pain prescriptions are an issue, then maybe seeking some kind of help from your primary care doctor or for somebody who works with your primary care doctor to get a referral to an addiction program. But if the issue is that your pain medication that you're not misusing, but your doctor's out of town, then I would try seeing, there should be a doctor on call for your physician. So I would call back the office, try to find out what doctor's on call, and see if that doctor can call you back.
Okay. Doctor, here's another email question. Why are fentanyl patches prescribed for pain if fentanyl is so dangerous?
Fentanyl, if used in the right circumstances, and with the right method of delivery, can be a very important medication, particularly for cancer pain and terminal cancer pain. These are people who have increasing amounts of pain. People will eventually get tolerant to these medications and need more and more. So someone who initially has pain, it's really severe pain, and the cause of the pain is not going away, such as some kind of terminal illness, then they will eventually need more and more potent amounts. But fentanyl, when it's prescribed in a patch, is in a very controlled delivery form, unlike buying something off the street.
All right. Has help me out here again.
Suboxone.
Suboxone, thank you, or Subutex help the epidemic, and what are the long-term effects of these? And I don't know if we've talked about Subutex yet. Is it related though, right? So
Suboxone and Subutex are both related. They're both forms of buprenorphine, which is that partial opioid agonist I described before. That is the ceiling effect. And they both can be used to treat addiction. Now, for the most part, the evidence is very good for their use in terms of reducing the amount of relapse, but it has to be done in a correct setting. So by a doctor who's prescribing it, also who's making sure that the patient's going through appropriate psychological treatment, who's also making sure that they're not misusing other substances concurrently. Then it can work very well. Right now, we don't see. It is still in the early stages of treatment. It was just approved, possibly about 20 years ago. So we're still in the early stages, but so far we do not see adverse effects. There's much less risk for overdose with these.
All right. Here's another email question. Doctor, I take 3 to 4 Vicodin tablets a day for chronic pain. Would you consider this to be an addiction problem?
From that amount of material, I can't answer the question
because we don't know how long you've been taking it.
Well, we also don't know the effects of it on you. We don't know how you're taking it. Are you using it for other things? Is it affecting your life? Are you combining it with other substances? Potentially, it's a complicated question. I would say that if the medication is having downsides, if you're craving it, if it's causing adverse consequences, or you're trying to get it from illegal sources, then maybe potentially. But people, in some instances that that is not going to be addiction. In many instances, it's not going to be. But at the same time, you'd be running your risk for developing a tolerance, which may ultimately put you at risk for addiction.
And obviously this is a question they could certainly ask their psychiatrist or their doctor, right?
Yes.
Yeah, okay, he's going to know it better than others. Here's another question, doctor. What steps are you taking at Oxnard to address the opioid epidemic, and how can a family member become part of your program?
So at Oxnard, we've started a big committee that's designed to prevent and address the opioid epidemic. We're trying to be more careful. We're providing education to patients as well as providers on the proper use of opioids, being more aware of the amounts and what are safe amounts and how they should be safely used, trying to identify patients who might be more, even though that is hard to predict. There are some guidance and basically looking at patients and seeing how they're doing over time, trying to direct those patients to the right resources. We also we do offer addiction services at Oxnard. So contacting, if you do go to Oxnard, contacting your primary care doctor and letting them know, or letting that you or a loved one is struggling with this, and then they can refer you for further help, or else contacting the scheduling and asking for an appointment with psychiatry or a primary care doctor.
Yeah. It brings up a good question. I just picked up a prescription, and I'm proud to say I don't take any drugs, but I needed a prescription for something. And it's got all the warnings on the paper. They give you 3 sheets of paper to read, and of course no one ever reads all that stuff. So before you're prescribing opioids, or anyone prescribes opioids, are patients being told the risk factors on the front end of things?
So up until now, I don't think they were. I mean, we do always have those theoretical discussions that happen, and so many doctors will kind of go over those with patients, and then you definitely get that from the pharmacist. But I think now there's becoming more and more awareness of no, we need to make sure that these are really spelled out for patients, because these are more subtle things.
And there are other alternatives.
Yes.
So a patient could say, that's not a risk I'm willing to take.
And then they can ask for things, the other alternative medications, such non-steroidal anti-inflammatories, things like acetaminophen, things like we use antidepressants for pain control. We also use, there's various different kind of nerve blocking or nerve modulating agents that we also use that can also be. Now, a lot of these will take some time to have an effect. And so a lot of times that may not be why people will jump to them as their first treatment, but that if used over time in combination with addressing the primary cause, with using a comprehensive approach to pain, that they actually will work better than opioids.
All right. I think this is the time, the last question we have time for tonight, Doctor. Do you think all high schools, and for that matter probably colleges too, I'll add that in there, should stock Narcan? And if you're just joining us, Narcan can reverse
Yes.
The overdose danger, right?
Yes. Narcan is also known as naloxone, and it's an opioid antagonist, so it blocks the opioids and basically can work very quickly to stop the effect of the opioids, and so can reverse an overdose. And so yes, I do think it would be very important that any nurse's station in a college or a high school should stock it, because just waiting for EMS, that's still precious time.
All right. It's been a wonderful program, great information. Thank you so much for being with us and for
pleasure.
your work at Oxnard, Doctor. Thank you. To make an appointment with any Oxnard physician, including tonight's guest, Dr. Velander, or to register for any of Oxnard's Hello Health seminars, here's a special number just for viewers of this program, 842-5669. That's 504-842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com. And Oxnard's got lots of the old programs too on oxnard.org. Our thanks again to tonight's guest. Thanks to Humana and Oxnard for making this program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and our station, WLAE. Good night.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live.